The final lecture, a patient with primary glaucoma who needs filtration surgery. So is your first filter going to be a trab or a tube? This is for primary glaucomas. Dr. Bindu Ajith, she's a very experienced high volume cataract and glaucoma surgeon from Comtrust Eye Hospital, Calicut.
Good morning, everyone. Thank you, Kiran, for this opportunity. Like Kiran told, it's a primary open-angle glaucoma, and the two surgeries offered are the trabs and the tubes. Now, when you have multiple options, the consideration you take into account is definitely the outcome, the efficiency of the procedure, and safety of the procedure, and the most important, the ease of doing it, or the technical skill of the surgeon matters the most, the learning curve, the cost and affordability, and how often can you repeat it, and most important, what is the evidence that literature has. Now, trabeculectomy remains the gold standard and is the most commonly performed surgery. But then, it is usually what we intend to is to get a low target IOP, and it is repeatable, and at least in this part of the world, it is the most like everyone is more familiar with this procedure, and you have much more literature on this procedure. But we do know it comes with a lot of complications like hypotony, hypotonic maculopathy, the suprachoroidal hemorrhages, and bleb-related infections. Like though we use the same amount of mitomycin for the same amount of time in different patients, they react differently, and it is not the same type of bleb that we get in all patients. It can vary from the cystic to thin-walled blebs, and that is the reason why it ends up in all these unpredictable results that we have. So that is why it is not indicated in all type of glaucomas, especially we need a lot of post-operative interventions also. Though we have the modifications where the efficiency can be increased by the modifiers like the mitomycin and 5-FU, and also with the use of releasable sutures, yes, definitely we can improve the efficiency, but it also comes with its own complications of the antimetabolites. So that is when we move on to look for a different surgery, that is the glaucoma drainage device. We have both the valved and the non-valved. It was usually previously reserved for the refractive glaucoma, but now we more into primary glaucomas too. And because it's a safer alternative to trabeculectomy, and there is a shift in trend towards the GDD. Initially, it was considered unsafe, but now we have more of this with the scleral patch graft and with the stents that we put the supralone and the supramid sutures, efficiency can be increased and the complications can be decreased in the GDD group also. Now, when we look at the trends, initially the trabs were on the rise, but now we see the trabs are on the down. And both for the primary and the secondary, the GDDs are on the rise. That is what literature says. Because the GDDs gives you a more consistent outcomes, and it is more posteriorly located blebs and with lesser post-op interventions and less risk of endophthalmitis. And the most importantly, like what the previous speaker told, the ocular surface disease, where the trabs outcomes are not very favorable, this comes in handy. And especially when you have a thin sclera or patients with rheumatoid arthritis where trab is not favorable, primarily we go in for the GDDs. And the complications of the post-op medications, the scarred conjunctiva, the scarred, there also GDD comes to our rescue. Initially, GDD was used only when you have a refractory glaucoma where the post-retina surgery or a failed trab. That was the time when we used to reserve these GDDs too. But the side effects are or the drawbacks are it has a more steep learning curve and the cost. But now we have the RD valve which is cost effective. And to repeat a GDD is more complicated than to repeat a trab. That is one drawback. And then the evidence when compared to trab is less. And we do have complications, yes, we do have complications of GDD with a tube exposure, with a tube endothelial touch and the damage, hypotony. All this is also there in the GDD. And especially the time taken to do a GDD is much more than what you do a Trab. So that is why initially GDDs were reserved to the uveitic glaucoma, the neovascular glaucoma, or the secondary group of glaucomas. Now we'll just see what the evidence shows that as a primary tube versus Trab study, which we have both the 1 year result, the 3 year result and the 5 year results are out. What does this say? It was a multi-center study with 16 centers, 242 patients, 117 underwent trabeculectomy and 125 the bowel implant. And then what is the 1 year result was trabeculectomy with mitomycin had a higher surgical success rate than the tube implantation, but the trabeculectomy people and the serious complication producing vision loss requiring reoperation was lower after tube. The trabeculectomy group had more complications. And this was same in 3 years also, but the difference between the IOP control between the two group was not significant. Again, the serious complications was more in the Trab group. And 5 years, again trabeculectomy with mitomycin and tube shunt surgery produced similar IOP, but the trabeculectomy group had fewer glaucoma medications after the surgery, and there was no significant difference in the rate of surgical failure between the two groups. So that was the statistical results. Actually, the difference in IOP was only around 2 or 1, and the medicine difference was 2 in one group and 1 medication in the other group. There was no much significant difference, and the complications they looked into was more of wound leak in the early stage in the trabeculectomy. So that is why the incidence of complications was more in the Trab group. So complications were more of hypotonic maculopathy was 2 in Trab group, and that is why the vision loss is more with the Trab group. Again, another study which also showed similar results, that two group had similar IOP control. There was no much statistical difference between the two group in a primary glaucoma. And this is a practice preference of glaucoma surgeon, a survey done in American Glaucoma Society. The use of GDD has increased and that of Trab has come down concurrently, but still trabeculectomy remains the most popular primary incisional surgery performed. So now to answer whether you will do a Trab or a tube in a primary glaucoma, definitely we'll all go with, I think at least in this part of the country, we go with a Trab in uncomplicated primary glaucoma, except when you have a scarred conjunctiva or you have scleritis or scleromalacia, and when you have more risk of hypertony or you have like a risk of expulsive hemorrhage like the Sturge-Weber, there you go for a glaucoma drainage device, especially the valve device, rather than going for a Trab there. Thank you.